All right. I have nothing to disclose. There's that question one more time. We're going to revisit this about mid-lecture here. So what I want to do in this talk is talk about infection in the spine and hopefully take things a little bit further than simple discitis and get into some of the intricacies of making this kind of difficult diagnosis to help out our clinicians. So what is simple discitis? Well, spondylodiscitis is a primary infection in the vertebral body and adjacent intervertebral disc. It has a pretty significant incidence in the United States, but I have a little bit of an issue with this concept of simple. The reason being, I get calls just about every single day to revisit the imaging on these patients and answer the questions, do we think it's really infected? Could this be some kind of atypical bug? And is our treatment working? So the goal of this talk is going to hopefully give you the tools that you need to answer these questions more accurately and efficiently for your referring clinicians. So we're going to start first with spondylodiscitis and talk about the most common bacterial or pyogenic spondylodiscitis, which is the spondylodiscitis we typically see in our IV drug abusers, our diabetics, our patients with chronic immune deficiencies. It typically involves the lumbar spine, and it's caused by the Staph aureus species in most cases through hematologic spread. Now, when we get into our older patient population, we have to start considering the possibility of retrograde spread up through Batson's plexus that's going to bring up those weird E. coli species, the weird Enterococcus species as well. So just like any good radiologist, we're going to start with a radiograph, and we're going to be looking for those specific findings of end plate erosions, of relative osteopenia, and of disc height loss. But we are going to remember that these findings take a long time to show up to 3 weeks after that inoculation of the vertebral body before we're going to see anything on the radiograph. CT can be a little bit more sensitive. We can pick up subtle end plate erosions and disc height loss, but really MR is going to be our diagnostic gold standard. This is the typical protocol that we use. Always give that post-contrast imaging unless it's contraindicated, not because bone marrow edema makes any difference, but because we want to pick up subtle abscesses. So I ask the residents every time they rotate through, tell me the typical findings of osteomyelitis discitis. And I hear the same thing over and over. Bone marrow edema in 2 consecutive vertebral bodies, fluid within the intervertebral disc, and I'm going to tell you, forget about it. This is a very nonspecific finding. You can see this in patients with modic changes. You can see that fluid in the disc in patients who have an unstable spine. Micromotion, neuropathic spine can all give you these findings. So think about how we approach osteomyelitis literally anywhere else in the body. Think about a diabetic foot. We focus on the T1, right? We talk about the replacement of marrow on our T1 weighted sequences, but for some reason we abandon this in the spine, and I don't understand why. So I'm going to bring things back. Let's go back to the T1. Let's look at the marrow replacement and use that to our advantage. And I use a cutoff of 50% of that vertebral body height. If I see low T1 signal involving more than 50% of that vertebral body, I'm going to be concerned about the possibility of infection. Now, the post-contrast imaging can be helpful as well. If we see prevertebral soft tissue edema, epidural enhancement, and in the late stages, we may even see a psoas or paraspinal abscess. If you see a psoas fluid collection, it's infected. That's pretty much a slam dunk diagnosis. Now, the T2 weighted sequences are not completely useless. Spear in 2015 talked about paraspinal or paravertebral inflammation measuring more than 5 millimeters being highly associated with culture positivity. So if you have that paraspinal edema, measure it. If it's more than 5 millimeters, increase that suspicion for infection. Now, Method in 2022 talked about a similar finding. They talked about the CYPER ratio, which is the ratio of paraspinal edema, and they said if this is more than 2.5 times the height of the vertebral body, that's also highly associated with discitis over other degenerative changes. And you can also measure this off to the side if it's more convenient for you. Now, I really loved this article and this finding. This is Schwark and Niemak in 2020, talked about end plate indistinctness. So look at the first couple of images here in modic change. You can see that end plate very, very well across the entire length of that intervertebral disc. But in the infection cases, we start to lose it. So I actually use end plate indistinctness quite a bit when I'm trying to assess modic change versus infection. So take a look at this case. This hopefully shouldn't be too much of a diagnostic mystery for anybody. we've got a ton of edema in this L5 and S1 vertebral body. Look at all this low T1 signal, clearly involving more than half of that vertebral body. We've even got this little epidural fluid collection and a psoas or paraspinal abscess, cinching that diagnosis of bacterial spondylodiscitis. What about this one, though? This was a patient who came into the ED. They're obviously in pain. They're wiggling around. We see similar findings, but it's a little bit less distinct here. We've got some fluid in the disc. The T1 signal is it's just a bad scan, but also they're sort of heterogeneous in their marrow. It's kind of hard to tell. Maybe there's a little bit of paraspinal edema. What do we do in this case? Well, this is where temporal changes in bacterial spondylodiscitis come into play. And if you're going to remember nothing of this entire lecture, please remember these next couple of slides, because this is where we fail as radiologists and where we can be so much better if we just try. So by temporal changes, I mean what happens early and what happens late. So let's talk about early temporal changes. Obviously, early on in infection, it can look very similar to modic change, and it can be very difficult to come down hard on infection. So what do we do in that instance? Like in a case like this, a little bit of disc height loss, a little bit of low T1 signal, and honestly, what looks to me like a acute disc herniation. I don't think I would be too worried about this case, but they had very high clinical suspicion. This was an IV drug abuser. They had elevated inflammatory markers. According to Dunbar and Radiology in 2010, what we should do is start antibiotics and then repeat imaging in about 8 days and see if there's any change. So in this case, we see that little bit of fluid has now appeared in that disc. We have a little bit more low T1 signal, and we've got the presence now of a little bit more convincing epidural collection. So start the antibiotics and get follow-up imaging. So if we have a question coming out of the ED, we can now help direct our referring clinicians. We can say, you know what, it's a little bit unclear. You have high clinical suspicion. Start that clindamycin, bring them back, and we'll re-image. So let's go back to our question case here. This patient did come back for a repeat MRI 10 days later, and everything's much more clear now. We've got more bone marrow edema, more low T1 signal. Now we've got enhancement both in the bone and in the epidural space as well, and we can see a little bit more easily that paraspinal edema as well. So let's talk about late temporal changes. This is where we really screw up, I think, as radiologists. And this is the dilemma of treatment response. So let's take this case. You've already seen it. 55-year-old male with Staph aureus, very clearly infected, low T1. We've got that epidural abscess and the psoas abscess. Patient was admitted, put on 5 weeks of IV antibiotics. They improved clinically. Their inflammatory markers improved. So the clinicians are feeling great. They're going to let this guy go home. What do they do before they let him go home? Well, they're going to get another MRI to make them feel warm and fuzzy. And I'm going to tell you, it never does, because it looks terrible. So this was their follow-up before they sent them home, and this got read out as worsening osteomyelitis discitis. So now you've put the clinician in this really awkward position of, well, shoot, is there another bug? Do we need to re-biopsy this patient? Do we need to change our antibiotic therapy? And you run them down this rabbit hole that's very difficult to get out of, when in reality, this is all very expected and normal. So bone marrow edema and enhancement is expected to worsen for up to 4 months after appropriate antibiotic therapy. This is because infection damages the bone, and it damages the stability and integrity of the spine. So you're going to see a lot of remodeling and changes happening in the bone for a long time. Think about fractures. They take a long time to heal. So the best thing to do is pay attention to what's happening in the soft tissues. Look at this abscess. It's gone. The paraspinal edema and the epidural abscess also gone. If you can convince yourself of that, you are appropriately treating this infection. Keep doing what you're doing. Let the referring clinician know that this is expected up to 4 months. Have them come back, in 6 months if they really want to take a look and see what's going on. So back to our question. What is the most sensitive specific finding for appropriate antibiotic response in bacterial spondylodiscitis? It's improved soft tissue swelling and abscesses. All of these other findings may worsen for up to 4 months. Okay, so let's get to mycobacterial spondylodiscitis, or TB spondylodiscitis. Now, differences in this infection over pyogenic is that it likes the thoracic spine, to the point where I would say if you see isolated infection in the thoracic spine and nothing in the lumbar spine, start thinking about TB or your atypical infections, because pyogenic Staph aureus really doesn't isolate to the T-spine without having intervention in that area. The other thing that's specific, as we all know, probably from residency, is this subligamentous spread. What does that mean? Well, TB does not have proteolytic enzymes, so it can't bust through into the disc and it can't bust through the ligament. So it has to track underneath that ligament to that adjacent level. And that's what gives it that classic disc sparing that we see in mycobacterial spondylodiscitis. So let's take this case, really gross looking POTS deformity. You can see involvement here, but look at that tracking of infection down to the adjacent level. Here's another deposit. You can actually see that high T2 signal tracking underneath that ligament to the adjacent level, sparing those intervening intervertebral discs. Now, this is maybe my favorite specific finding in TB, is this small rim-enhancing abscesses. So here we have a bigger abscess, but look at the level below. Tiny little interosseous abscesses are very specific for TB. This does not happen despite very extensive Staph aureus infection. It's very, very rare to get interosseous abscesses with Staph aureus. If you see that, think about TB or some other atypical infection. And then, of course, because of the disc sparing, we get more than 3 consecutive levels. You are essentially never going to see that with Staph aureus, because if you have 3 levels involved, that patient's probably dead. Okay, so key features: thoracic spine involvement, little interosseous abscesses, and subligamentous spread. So let's get to fungal spine infection. I call this the great mimicker because it can look like just about everything. This is a case of Candidal spondylodiscitis, looks very much like our pyogenic with disc-centered involvement. You've got the changes in the adjacent bone. You've got a little bit of epidural enhancement. This probably needs a biopsy and culture to tease that out. These are cases of coccidiomycosis, big paraspinal abscesses, little interosseous abscesses. Looks very similar to that case of TB that we saw. Another case of coccidiomycosis, prevertebral abscess, interosseous abscess, and we've even got kind of that classic POTS deformity. So coccidiomycosis in particular can look very similar to TB. So they often kind of go hand in hand, and we do those mycobacterial cultures alongside our fungal cultures for that reason. Now, this is probably the least common but my most favorite mimicker, and it's this multifocal nodular involvement of bone. So this patient came into the clinic, was kind of indolent, long-lasting back pain. They got an MRI, and look, we've got these lesions, these T2 hyperintense lesions in the vertebral bodies. They have low T1 signal, they enhance, and we've even got little spots in the pelvis. So this was called probable metastatic disease, and it should always be called probable metastatic disease. But it was biopsied, nothing came back. It was biopsied again, nothing came back. And finally they said, well, shoot, just send it for some cultures or something. Came back as coccidiomycosis, disseminated coccidiomycosis of bone. Now, in no way should you get this case and say, disseminated coccidiomycosis of bone. This is only brought up so that you have that in your arsenal if things start looking weird on your biopsy. Okay, so how about advanced imaging? So there are some advanced imaging available when trying to differentiate degenerative versus infectious discitis. The first of which is from Patel and the AJR in 2014, talked about using diffusion-weighted imaging to look for this claw sign that we see in modic changes that we don't see in our degenerative, in our infectious cases. So look at the 2 examples, degeneration versus infection. That first one, you can see that claw sign. The diffusion restriction in infection is much more diffuse. Now, I would say using my trick of the T1 works just as well in their example. But if you need that extra little bit of oomph, this is something to consider. And then lastly, the iron oxide injection that was discussed by Berry et al. Is basically an injection of the superparamagnetic ion that gets phagocytized by macrophages in infection, and it results in the signal dropout on the T2-weighted imaging. Here in infection, you can see that dark signal along the end plate that we don't see in the case of degeneration. So this is not something to throw into our routine imaging, but if you need something extra, just know it's available. Okay, so now I want to talk for just a second about post-operative fluid collections. Now, post-operative spine is, of course, in and of itself an entire lecture, but where I think we really fail is trying to make heads or tails about post-operative fluid collections. I think we can do a lot better. So post-operative infections are common. They're particularly common in posterior approach. So if you have an isolated anterior approach fusion of the spine, it is very rare to get infected. Posterior approach make up 98% of the infections that we see. Soft tissue infection is the most common, and how that typically manifests is the presence of an abscess. The problem is that there are a lot of mimickers, seromas, dural leaks with pseudomeningoceles, hematomas. So how do we start to tease these out? Well, here's an example of an abscess. You can clearly see this thick rim enhancement. There's a lot of adjacent edema. We all know that that's an indication of infection, but other things that we can use, the T2 signal in an abscess tends to be more complex or lower than the other causes of soft tissue fluid collections. So look at this T2 signal. Much more complex. You see this internal temptation. That's the debris in that purulent material. The other thing that I really like to use when I'm assessing postoperative fluid collections is this convexity to the margin. So think back to your med school days when you did INDs in surgery. Abscesses are positive pressure environments. You cut into that thing, all of that pus oozes out. I thought it was very satisfying. But how that's going to manifest on imaging is this is going to be a convex margin. It's very hard to have an abscess full of pus without having that pressure against the wall. So let's take a look at the seroma by contrast. So we've got a more thin rim of enhancement. Look at this T2 signal. Much more homogeneous, much more bright, and look at this concavity to those margins. This is a neutral or lower pressure environment. This one I'm going to favor seroma for all of those reasons. Now, seromas can have more of the convex margins. They can be a little bit higher pressure like this one, but again, the rim is so thin, there's no adjacent edema, and that T2 signal is very uniform and very bright. So what about our pseudomeningoceles? These happen from iatrogenic dural leaks, which can be up to 15% of spine surgeries. The important thing to remember about a dural leak is that 2/3 of them occur in the shoulder, or what's called the axilla of the canal, which is right here, right around those lateral recesses. Now, the signal within a pseudomeningocele is going to be similar to seroma. It's going to be very bright. It's going to be very homogeneous, and it's also going to demonstrate a pretty thin rim of enhancement. But how you can differentiate them, or at least maybe suggest that we're dealing with a dural leak, is trying to find this tail that reaches up to that axilla. Here's another example of that. This little bit of fluid that's really reaching a little bit too far up into that axilla. You can see there's a little bit of indistinctness to that, the dura, that this one I might suggest maybe this is a small dural leak. Similarly, in patient B, you can see that finger kind of extending up towards that axilla. Okay, so what about hematomas? These usually are pretty easy to pick up. You've got some T1 signal in them, and the complexity of these is really extreme because you've got a lot of clot, you've got various age blood products, etc. So the one pitfall with postoperative fluid collections that is incredibly important to understand is that of antibiotic beads. So if a patient has infection, a surgeon is going to go in and they're going to do a debridement. And oftentimes in that cavity, they're going to place gentamicin or vancomycin impregnated beads to provide local antibiotic therapy. Now the problem is that when these antibiotic beads resorb, they leave fluid in their wake. They create a very low-grade inflammatory response, and it's very important that we don't misinterpret this as a reemergence of that abscess or infection. So take this example. There are those beads. You can see them. They look like little tiny dark dots. In the follow-up imaging, the beads are resorbing, but we're seeing a little bit more fluid. That is normal. That is the expected response. Here's another example. Antibiotic beads are present. As they resorb, it's going to leave some fluid. That's completely expected and normal. Okay, so now let's talk about intervention, biopsy, the who, what, when, where, how on biopsying for osteomyelitis discitis. The yield of biopsy for spondylodiscitis is terrible. It's as low as 30%, and it's even worse when we do repeat biopsies. There are literally over 1,000 articles on this exact topic. So what I'm going to do here is really pare it down to the ones that I think are important. So in the first instance, we need to ask ourselves, is the patient clinically infected? Do they have elevation of their inflammatory markers? They have fever? On imaging, do they look infected? If you have these two together, I think it's not completely unreasonable to go in and biopsy and see if we can identify a bug. But what if we have an immune-compromised patient? According to Classic in 2018, all bets are off. In that case, you're not going to get the clinical picture. You may not get the imaging picture that we're expecting. So a biopsy is honestly pretty reasonable. One thing that you can do is look for the presence of positive blood cultures. We know positive blood cultures are going to have the same bug as what we pull out of the vertebral body in over 90%, 95% actually, of cases. So it's reasonable to ask yourself, is this a difficult patient? Is this an unsafe biopsy? If we have positive cultures, let's just go with what we've pulled out of the blood. What about on imaging? We already talked about Spear's article that talked about paraspinal inflammation of greater than 5 millimeters. This is going to increase our culture positivity. And obviously, if we have abscess, our culture positivity rates are going to go way up. So what about technique? I love this article by Kim in 2015 because it was so beautifully controlled. They took patients who had osteomyelitis discitis, but only those that had paraspinal or epidural abscesses. So there was no question that these patients were infected. And then they looked at the outcomes of biopsy of the soft tissues, which included disc, the paraspinal soft tissues, or an abscess, versus the vertebral body. And they found that the soft tissues had a culture yield positivity that was twice that of the vertebral body. So how this has changed how we do things is that I honestly don't biopsy the bone very much anymore. It's a hard sell to say we need bone when the bone culture yield is so much lower than soft tissue. The only reason to do bone is if for some reason they're needing pathology along with it. This has been confirmed with multiple additional articles, including the meta-analysis by Dr. Chang that was the most recent in 2022. What about antibiotics? This is such a highly debated thing in medicine. If antibiotics really actually affect the culture positivity, and the punchline is they probably don't. If you want a number, 3 to 4 days has routinely been shown to not make any difference in culture positivity through multiple studies. Dr. Chang's meta-analysis really concluded that antibiotics in any capacity really don't affect the biopsy yield. So what this means is if you get called over the weekend and you have limited resources, it's reasonable to go ahead and start the antibiotics and try and get them in when you can do them safely. So that's how this has changed how we do things in our institution. So if they're immune compromised, probably going to have to biopsy. If they're immune competent, maybe if they have positive blood cultures, if their imaging isn't really convincing, or possibly if they've been on long-term antibiotics, we don't biopsy. And then if all of those are opposite, we're going to go for biopsy, but specifically make sure that we're at least targeting the soft tissues along with the bone to increase our culture positivity. Okay, so in the last 5 minutes, I do want to talk about the differential diagnosis so that we have touched on a couple of other conditions that can give similar imaging and we don't get confused by these inflammatory diseases. The first of which is seronegative spondyloarthritis. And we're going to talk about ANCSPON, but we'll also talk about these other conditions as well. So ankylosing spondylitis, as we know, is a chronic inflammatory disease typically affecting young males, and it's this insidious onset where we get imaging features including syndesmophytes, squared vertebral bodies, demineralized bamboo spine, but where this can really be confusing for infection is when we have one of two different findings. One is the romanus lesion, which is an enthesitis that happens basically where those syndesmophytes are about to form. This could potentially throw you off that, maybe there's an infection going on. The multifocality should make that a little bit more obvious. The one that gets really confusing is the Anderson lesion, which is the inflammatory spondylodiscitis that happens along the end plates. You can differentiate this typically from infection. One, again, if it's multifocal, but also if it has that half moon shape, that curvilinear shape centrally in the vertebral body. Infection typically tends to be a little bit more linear. So now let's move to Sappho syndrome. Sappho syndrome is synovitis, acne, pustulosis, hyperostosis, and osteitis. This is a chronic relapsing rheumatologic condition, and it tends to affect the anterior chest wall. So the sternoclavicular joints, sternomanubrial joints, you're going to see this hyperostosis, which is the density, and the reactive change, the osteitis, the marrow edema. Now, in 30 to 50% of patients, you are going to see spine involvement, and what's really cool about the spine involvement is it affects these really oddball joints. So these costotransverse, costovertebral articulations, which don't usually have a lot of pathology associated with them, are the most favorite joint for Sappho syndrome. So if you see this hyperostosis, the osteitis happening in that area in somebody who has this kind of indolent, non-specific back pain, particularly if they're younger, start thinking about Sappho syndrome. Here's another case of Sappho syndrome. Looks very similar to those Anderson lesions we saw in Angst-Bond. And actually, there's been some suggestion that this could be at least on the spectrum of Angst-Bond, which is why we're getting very similar type end plate change. Okay, so how about rheumatoid? Rheumatoid arthritis, 40 to 80% of these patients are going to report some kind of spine involvement. The cervical spine tends to be way more affected in our male patients than in our female patients. And this is kind of the area that could potentially be confusing, this atlantodental area where we get this large pannus, you get a lot of bony erosions. It's possible that we could misinterpret this as potentially infection. Now, what about CPPD? This is our other arthritis. We know in the wrist, we get this calcium pyrophosphate deposition. It's also characterized by arthritis, joint narrowing, and cystic change. Now, the cystic change in CPPD is actually very important. It can be very profound. So CPPD involvement in the spine is considered to be an underdiagnosed, underrecognized source of occipital-cervical neck pain. On imaging, we have this classic kind of gold standard crown dens appearance, which is this linear CPPD that is in that alar ligament around the dens. But don't underestimate the importance of seeing these big cysts to kind of cinch that diagnosis. And also, don't underestimate how big these things can get. This was a case of CPPD. We've got that clear deposition in the ligaments around the dens. Look at this cyst, though. Decompressed out the back of the bone, still had a little, it was still kind of contained within some of the ligamentous structures. This was thought to be some big mass, and then later found to just be a CPPD cyst, but it's clearly causing a lot of issues with some foramen magnum narrowing and some cord impingement. And then finally, I want to talk about polymyalgia rheumatica. This is just kind of near and dear to me because we had a case of this that was underdiagnosed for a long time. So this is an inflammatory disease of elderly women. It's an unknown cause, but it causes a synovitis and a vasculitis that tends to involve large joints, your shoulders, your knees, your ankles. You get this kind of relapsing synovitis. But in the spine, what polymyalgia rheumatica likes to involve is this interspinous ligament and interspinous bursa. Here's just a couple examples from the literature. Here you can see all of that interspinous inflammation. So it's something to consider. This was a patient from our institution, came in with inflammatory markers. You can see that little bit of fluid in the interspinous bursa. It's kind of decompressing out there into that retrodural space. This was called an abscess, which would be, it'd be a little odd to have a dorsal abscess anyway, but she was put on antibiotics long-term, wasn't getting better, came back, and now she has SI joint involvement. Then we started looking back through her jacket, and she's got imaging of her knees, imaging of her shoulders, imaging of her ankles, of her hands, that has lasted for years. So we considered this diagnosis. She was seen by rheumatology. She was treated appropriately, and all of her symptoms disappeared. So in conclusion, we talked about the imaging features of bacterial, fungal, mycobacterial spondylodiscitis. We talked about temporal changes. So again, please remember bone changes look worse for up to 4 months. Look at the soft tissues to evaluate whether somebody's responding. We talked about some advanced imaging techniques, the post-operative fluid collections, and kind of tricks to at least help guide the clinician on what the etiology of the fluid collection is. And then biopsy, who, what, when, where, how, and differential diagnosis, particularly Angst-Bond, rheumatoid, CPPD, and PM&R, which can look very much like infection. So thank you very much for your attention.